or whatever.
Okay.
So no worries. So as I said to Miss O'Neill, Princeton's a little bit of a conundrum. He's behaving a little bit different than many typical term babies, in that when he first arrived and he had some x-rays done, there were some changes in the bowel. Now I will say x-ray's not perfect for looking at this, but it was pretty clear that he had what we call gas in the intestinal wall, and the medical term for that is pneumatosis. Pneumo is air, tosis inside, maybe, I don't know, can't tell you what tosis is. Anyway, it's air inside the wall of the bowel. So air should be inside the bowel, not outside of it, and not in the bowel wall. And that finding on x-ray goes along with a medical diagnosis called necrotizing enterocolitis. It's an inflammation of the bowel, not always caused by infection, although we always treat with antibiotics because we don't always know what causes it, but antibiotics are easy to use. So we always treat with antibiotics, although we don't know exactly why they get it. The reason Princeton's a little bit different and just has us thinking a lot about him is because it is not common for term babies to get this. So 80% of cases, so if you took 10 babies, 8 of those 10 who got it would be preterm. It's pretty rare for term babies to get this. And when they do, to the best, we start looking for other things. So when term babies get this, sometimes they also have heart disease. So we did an echo and he doesn't. Now there's some changes to the size of his heart where it's bigger than typical, and that's just related to diabetes, and that's we knew that was probably we knew we were going to find that, but that wouldn't explain the bowel findings, and that will get better with time. Like there's nothing to do about that. It's not causing him a problem. He's safe, and it will resolve over time. So we don't need to treat it with medicine. We don't need to do anything about it. And because it's so unusual for us to see this finding on x-ray in term babies, we followed a whole bunch of x-rays, and it was present on the first 2, but it has gone away. So it's not still there, and we did an ultrasound in which it is not still there. Now I will say for neck, that's what we expect. We actually expect the x-rays to normalize. So we expect to find it, and we find it for anywhere from 24 to 72 hours, and then we expect it to go away, and that's what happened. But we tend to not feed the bowel for about a week, sometimes even 10 days, depending on how severe it is. Because even though the x-ray finding has gone away, we don't have a good idea of whether or not the bowel is still inflamed. So there's no test to kind of look and see, hey, bowel, are you still angry? Right. The only test for that is a surgery, which he does not need, so we're not doing that. And so, we have, Miss O'Neill, as you and I, and then with my colleague before, Dr. El-Shanawi, we've sort of been going back and forth on a daily basis, trying to be like, this is just unusual. We don't want to commit you to this full course if we don't need to. At the same time, neck can be so severe and can cause such problems. The last thing I want to do is feed the gut if it's still inflamed and then get into a bigger problem or cause it to reactivate and kind of become a problem. So yesterday, the blood test that we did that look at infection fighting cells and measures of inflammation had gone up. So they had previously been normal, and now they were too elevated. And that, again, just even though the x-ray was better, all of that just to me said, listen, let's just fish or cut bait. We need to call this neck, treat for 7 days, and then restart feeding. The way we restart feeding is typically slow. For him, it would be with a bottle. We would limit him for the first sort of 48 hours to something that he's not going to be happy not eating. Like, that's baseline. We know that. And we'll limit him when we do start to feed him. But term babies are pretty good at regulating. So if he feels like eating once we allow him to, after we kind of go slowly for the first couple of days, we'll kind of take his lead and let him feed on it. So that's kind of and during all of this time, we do antibiotics that cover sort of gut bacteria, typical gut bacteria. So he's on 2 right now, one called vancomycin and one called zosyn. The blood cultures that we repeated yesterday, if those are negative tomorrow, we'll stop one antibiotics, the vancomycin, but we'll keep on the zosyn. That's a relatively broad antibiotic, meaning it covers a lot of bacteria, and it covers bacteria that can grow in the gut. Okay, and that would be the antibiotic that he would stay on. Those first days of antibiotics that he got, like when he arrived, those count towards our 7-day count. Okay, so we're already 3 days into, we're already 3 days into this. Okay?
Yeah.
So we're 3 days into this. We're not starting 7 from your decision.
Okay.
The days he's gotten counts, because even though we switched up antibiotics, the ones he was on really are okay. So those days count. We're kind of on day 3-ish now, and we'll do 7 full days. And then the time to get up to goal, sort of fully feeding, again, for preterm babies, that can sometimes take up to 2 weeks after the antibiotics finish. I don't think he's going to need that, but I would anticipate about a week after the antibiotics finish. So sort of, I think if you have in your mind that he's here for about 2 weeks, now if it ends up being 2.5, don't be too mad at me. And if it ends up being 1.5, you can be thrilled with me. Okay? So I can't, the only one who's going to determine how long it takes him to get up to feeds is going to be Princeton. But given how he's acting, I think once this treatment is all said and done, I anticipate he will feed well, and we will get him home to you. Okay.
So
the PICC line.
Yeah, so the PICC line. So I say all that for background and context. So the way we will give him nutrition and the way we will give him hydration and the way we will give him his antibiotics is directly into his veins. So if you look up, there's this bag here. So that is nutrition. So that actually has protein and has sugar. And then this white tubing here has fat. Okay. So that is what we call IV nutrition, or you'll hear us refer to as parenteral nutrition. And we're giving that through this IV that is going into his arm right now. Okay. When we give IV nutrition through a peripheral IV, we can give what is the equivalent of a salad and grilled chicken. That's kind of the level of nutrition we're giving him. We're giving him a salad and grilled chicken.
protein.
That type of thing.
Yeah.
Through a PICC line, or what's called a central line, we can actually give him the equivalent of steak, potatoes, and a milkshake, if that makes sense. So we can give him a lot better nutrition through that central line. It also allows us to have a secure access, meaning we know we have access into his veins. We know we can keep him hydrated throughout this course. We know we can give him good nutrition, and we know those antibiotics will go in. Okay, so these IVs, the peripheral IVs, like what he has now, they tend to in babies last, sometimes if we're lucky, 3 days, but usually 1 to 2 days, and sometimes less than that. And then they become quite difficult to obtain, and he's sort of proven a little bit of a challenge, or and I don't know if you're a challenging IV stick when you needed IVs for your delivery, if you had to have a couple sticks, but sometimes babies can kind of be the same way. And so attempting a PICC line in him would allow us to sort of have that secure access. Like everything, right, we sort of talked about there's risks and benefits to everything that we do here. And, there's also no guarantee that we'll definitely get it in. The nurses are going to give, we're going to try. We do this all the time. This is very routine for us. And we're, there's nothing unusual that it wouldn't go in, but it definitely might not. And then we're left with what we can do. We're just left with the PIVs. But I think it's very reasonable to try. The downside, so the risks. So the benefits, again, are secure access. No matter what, we can hydrate him. No matter what, we can give him antibiotics, and we can give him good nutrition. The downsides are infection. So anytime you put anything foreign inside the body, it can get infected. Okay, so earrings can get infected. You know, anything that's inside you can get infected. To try to prevent this, the PICC line is put in right here, but without anyone else at the bedside besides the people doing the procedure, in what's called a sterile fashion. So, you know, the skin is cleaned of bacteria. Everyone's got hat, cap, gown, mask, all the stuff. And when it's finished, the dressing is what we call occlusive and sterile, meaning the skin underneath it has stayed clean. And the nurses keep a very close eye on that dressing to make sure that it stays stuck down and sterile, so that we reduce any potential risk for infection. Another risk factor is clotting. So anything inside of a vessel can cause a clot. So you stick anything inside your vein, you can get a little clot there. The little PIVs will cause tiny little clots in these vessels. Those eventually go away, but the PICC lines can cause clots as well. It's less common in lines that are in for a shorter period of time. So his would be a shorter period of time.
Okay.
A week, 10 days is what we're anticipating him needing this.
We're 3 days already in.
We're 3 days in, but remember, when he starts to feed, he's still going to need it because he won't be able to fully feed right away. He's only going to take a little bit by mouth and so he's still going to need support in the background with the nutrition until he can fully take his nutrition into his belly. So he will still need it even after the antibiotics finish, but that is when we will be working on transitioning. So every day what we do is we allow him to take more by mouth and we come down on that nutrition. And then the major, so the most significant risks, but fortunately the rarest, occur if the line is not in the right position. So the line goes into the arm, the leg. Sometimes we even start in the scalp, and the line feeds down or feeds up and ends in a big blood vessel near the heart. We don't look there first.
We don't look in the head first.
We don't look in the head first. That's our last ditch location. Okay, I promise. We don't look there first. Sometimes we have to, but that's not our first. Our first is, I like legs. It's my preference. But legs, arms.
Meaty.
And it ends, if it's coming from an arm or the scalp, it ends in a big blood vessel here near the heart. If it's coming from the legs, it ends right below the heart. Near the heart, not in the heart, okay? Or sort of right at the entrance of it. And those vessels there are bigger. So they're nice and wide open, and they can take the nutrition that we want to give it. So these little vessels here, so the catheter that's in this little PIV is very short. It goes in and it just ends right there. And these little vessels are really tiny. So they can't take a lot of volume. They can't take a lot of stuff in them. They're kind of wimpy.
Right.
These vessels are big, and they can take more stuff in them, like that good nutrition that we want to be able to give to him. If the catheter doesn't end in the right place, so let's say it pokes through a vessel and ends in the skin or the lungs or the heart, that causes what we call an infiltrate, okay, and fluid leaks out. If it's in the skin, you'll see a swelling of the skin. Again, the solution is to remove the catheter. Significant problems can happen, obviously, if that catheter ends in the lungs. You can imagine, right? Putting fluid in the lungs is no bueno, okay?
No bueno.
So we remove the catheter, and sometimes we even have to do a procedure to remove the fluid from the lung, okay? And then obviously ending around the heart is also no bueno, okay? So those are also bad things. It's important that you know these are risks, okay? But they are very rare, okay? And the solution is remove the catheter and remove the fluid, okay? To make sure that the catheter is in the right place, we monitor them with x-rays. So with an x-ray, we can see where that catheter ends. We can make sure that we like where its location is. And then the nurses as well, the catheter, there's a portion of the catheter that's outside the skin, and that has markings on it. And so every shift, the nurses look at those markings to make sure that they're in the right spot, that hasn't moved. If they have any concern that it's moved, let's say, and the most common time it moves is, let's say, the dressing, the covering starts to come up. Thus, that needs to get replaced to make sure it stays sterile. With the replacing of that dressing, sometimes it can move. That I'm just it doesn't happen often, but if it's gonna move, that's usually what happens. So then we would get a film. The nurses would let us know, okay, the catheter went in a little, the catheter came out a little bit, let's get a film, let's see where we are, and then we would adjust. So we monitor them when we put it in. We automatically monitor them twice a day with measurements. We get routine weekly x-rays to make sure it's moved, and then we would get an x-ray any other time that we had a concern that something had changed.
It's the least form of risk.
Yeah, I mean, the alternative, right? The alternative is that we keep using these IVs. They can infiltrate as well. Again, if you infiltrate in the hand, that can actually be problematic depending on what's going through it. But it's not like infiltrating into the lungs. Okay, I get it. So I don't want to say, but these can do the same. They can infiltrate. We can't give quite as good nutrition, and ideally we give some additional minerals that aren't as well tolerated in these PIVs. Calcium and phosphorus aren't as well tolerated here. They cause those infiltrates as if we were doing it in the big one. And then there's the risk that, if for some reason if he kicked it out, or if it just came out because it infiltrated, which they do, or it leaks, and then if we were not able to get another IV back in, and we weren't yet ready to feed him, we would be stuck in an emergent situation, where sometimes even we've had to move babies over to the children's hospital for the surgeons to put in a surgical line. So I'm really trying to avoid us even having to think about that. Now, like I said, there's no guarantee we'll get the PICC line. So, I mean, we do this all the time. It's a very routine procedure for us. So I'm very confident in trying, but nothing's guaranteed. So, but I don't want us to be kind of emergently having to do anything.
All right.
Okay. I think if all he needed through the PICC line was the antibiotics and he could get his nutrition and hydration through feeding, I would be fine with just getting by with this PIVs. We've got other tricks we can do with antibiotics, even though it's not pleasant. Some of them can be given as a shot. There's other things we can do for that to mitigate a couple additional days. But from a hydration and nutrition perspective, really the best option for him, is the PICC line. And y'all can,
I think it's okay, partially because of the risk, but because the risks are so low, that makes me feel a little better. But as far as us being able to see him every day,
you can see him anytime. It's just during the procedure. You can't be here, but you can, just like you're holding him now with these IVs, you can hold him, you can do skin to skin, you can do all those things. It's just when the PICC line at the moment that PICC line's put in, I'm not even standing, our nurses are at the bedside who are doing it. You just can't be here physically when they're putting it in, that's all. But other than that, you can be here anytime.
Sure will be here.
Yeah. Okay.
What you think, sir? It's I'm in if you in. Cause that's gonna feed.
Take good care of him.
That's gonna feed them. We need that. We need all that. And look like he need all of it too. Enjoy. Big by Jakarta.
No, I can't guarantee he's going to be happy with me, but I'm not letting him eat. In fact, he probably not gonna
He's
like
gonna
me
be
very much,
pissed.
but I'm gonna tell him that my name is Val, my good friend right here. And so when he
Amen.
asks, hey, hello, who didn't let me eat in my first week of life? I'm gonna say, oh, it was that woman with the nice Irish accent. Her name is Val.
Yeah, she got in the way.
Yeah, it's her fault.
I can take it. I can take it.
I never want the babies to be mad at me.
I know.
He's so content right now.
Well, as long as he can get this, it makes
I know.
everything better.
Yeah, it
Just
makes
so you
everything
know.
better just being held,
Yeah.
being with mommy.
Yeah, it makes everything better.
Okay. All right, honey. I do have a form that you have to sign to make it official. I know. Roll your eyes. I know.
No, everything has a form. in
Everything
here,
has
okay?
a form.
Yeah, everything has a
My
form.
life has a form.
Yeah.
Everything has a form. Do you know how many forms I sign without even?
I know. People say it all the time.
Like, you could be
Yes.
asking for my firstborn, and like,
I know.
I wouldn't know. Sometimes.
Correct.
I
Actually, I
just-
think I have your first and second born.